Welcome to the Milken Institute Future of Health Summit. We are delighted to have you join us and look forward to your participation over the next few days. To kick off the event, please welcome Executive Vice President of Health at the Milken Institute, Esther Krofah.
Good morning and welcome to the 2023 Future of Health Summit. Whether you're here in the room or watching online, we're delighted to have you join us. Gathered here are hundreds of leaders from across the health sector, representing government, philanthropy, care delivery, industry, academia, research, patient advocacy, the investment community, and more. We come together because we recognize we can do more collectively to achieve better health for individuals and patients than we can do alone. I've engaged with many of you across our work at Milken Institute Health throughout the year, and what I have found to be the common thread is partnership. Collaboration across disciplines and sectors is not just good practice, it is essential. Government and industry, academia, healthcare delivery systems, nonprofit, retail, and more are leading the way in forming new partnerships to address growing domestic and global health challenges. Our theme for this summit is Closing the Gap, Better Health for More People. This theme is particularly timely as we more fully emerge from the COVID-19 pandemic and survey the landscape. We see widening inequities in health here in the United States and around the world. The trends in the United States are particularly stark. Despite spending more than $4.1 trillion on healthcare, the most in the world, health outcomes are on the decline. The Washington Post's recent analysis revealed life expectancy is the shortest it has been in 2 decades, 76.4 years, taking us back to the mid-1990s. In 25% of our counties, people are dying at a higher rate than 40 years ago, particularly in the nation's interior, the Midwest, and the South. The gap in mortality between the rich and the poor is growing significantly wider. Taken one step further, people in both the poorest and wealthiest communities in the US live shorter lives compared to their peers in Canada, France, and Japan. An epidemic of chronic illness is our greatest threat. Heart disease, cancer, diabetes, liver disease, and obesity are among the primary reasons for poor life expectancy in adults aged 35 to 64, compared to other high-income countries. And this is despite the tragic deaths related to COVID-19, the opioid crisis, and gun violence. Life expectancy, however, is just one health outcome. Unfortunately, the health burden on communities across the country is also taking an economic toll: increased poverty, unemployment, inadequate housing, violence, and more. At the same time, we live in the golden era of science and technology. The breakthroughs and rapid pace of innovations in medicines, vaccines, diagnostics, new modalities of care delivery, and application of technology should be boosting lifespan and quality of life across all communities. The challenge and the opportunity I pose to you today is: how do we close the persistent gaps between innovation, access, and outcomes? How do we innovate our innovations to reach more people? Though we come to the table with different perspectives on how to close the gaps, we are united by a sense of urgency and a common goal for better health for more people. I have seen firsthand how bringing together cross-cutting sectors in medical research, public health, food systems, and healthy longevity enables us to develop better, more holistic solutions. And as we look across the lifespan, we must also consider how to maximize the quality of life for an aging population. By 2030, 1 in 6 people in the world will be aged 60 years or over. While this shift in an aging population began in high-income countries, it is now low and middle-income countries that are experiencing the greatest change. To elevate and prepare for an aging population, an ongoing area of priority for the Milken Institute, I am pleased to announce today the new Aging Innovation Collaborative. This collaborative, thank you. This collaborative is led by the Milken Institute's Future of Aging and established with a $3 million contribution from the National Investment Center for Seniors Housing and Care, which includes a contribution of the intellectual capital and fellows at Nexus Insights. Joining me on stage now is Ray Broen, President and CEO of NIC, Bob Kramer, founder and fellow at Nexus Insights, and co-founder and strategic advisor of NIC, Susan Barlow, co-founder and managing partner of Blue Moon Capital and board chair of NIC, and Diane Tai, senior director, Milken Institute, Future of Aging. Welcome, thank you so much.
Yes, thank you, Esther.
Thank you, Esther. As chair of the NIC Board of Directors, I first want to say how pleased we are to provide the seed capital for the Aging Innovation Collaborative in connection with the Milken Institute. NIC, representing the senior housing and care industry, shares the Milken view that public and institutional private companies propelling healthcare, housing, and communities for our aging population are not adequately prepared to meet the opportunities and challenges. Preparing for an aging population is a priority for the Milken Institute. Improving access and choice in housing and support services for older adults is NIC's mission. We're excited for the Aging Innovation Collaboration to identify scalable solutions and then fast-track their implementation. Time is of the essence. Thank you for the opportunity to collaborate. I'm excited about the impact we will have working together. Thank you.
Thank you, Susan. I'd like to thank all of our sponsors for making this event possible. I hope that over the next 3 days, you will walk away with fresh ideas, new solutions, and examples of how to implement them on the ground. I encourage you to move beyond your traditional areas of work to explore new areas and potentially form new partnerships and collaborative efforts. Thank you very much, and I hope you enjoy the conference.
We gratefully acknowledge the participation of the following organizations, whose generous support makes this conference possible. Thank the following media partner for their participation at this event. We thank the Milken Institute's strategic partners for their year-round support of our work around the world. Please welcome the panel to discuss Closing Gaps in Health and Healthcare, moderated by CNN medical correspondent Meg Terrell.
Well, hi, everybody. Excited to get started. This is going to be a really fantastic few days with some really fascinating looking panels coming up. I'm really delighted to get to have this panel of folks really spanning all aspects of the healthcare system to start off this conversation. So I'm going to introduce everybody, and then I thought maybe we could start by kind of setting the stage and framing the question that we'll be talking about this morning by having everybody kind of tell us where they're coming to it. So to my left is Dr. Jaewon Ryu, President and CEO of Geisinger. We have AmirAli Talasaz, co-founder and co-CEO of Guardant Health. Dr. Ashwin Vasan, the Commissioner of the New York City Department of Health and Mental Hygiene. Hubertus von Bonbach, the CEO and Chairman of Boehringer Ingelheim. And Angela Williams, President and CEO of United Way Worldwide. And Angela, why don't we start with you? Tell us about sort of a little bit about your organization and how you're coming to this question we're talking about today.
Thank you, and good morning, everybody. It's good to see all of you, your beautiful smiling faces. I am so pleased to be the President and CEO of United Way Worldwide. Many of you have probably heard the name, but didn't really understand the scope of our organization. We have 1,100 local United Ways operating in 37 countries. Here in the United States, we cover approximately 98% of communities. When I think about our organization and our areas of focus around health, education, and economic mobility, as well as climate and disaster relief, what really strikes me is that we have an asset that I want you all to know about, and that is 211, which is a health care, mental health, social services call center. United Way operates about 60% of those in the US, and it is the single most important tool that you all should recognize and know about and engage with, because we touch 20 million Americans a year that call us for support for healthcare resources, to be connected to caregiver resources, and so forth.
Hubertus?
So we are a research-driven pharmaceutical company. We research, develop, and bring to the market the products we produce on the animal health side, as well as the human side. We've been doing this for almost 140 years now. So we've been building an organization that is rather diverse in the targets we look after, whether it's oncology, whether it's depression, whether it's cardiometabolic diseases, lung insufficiency. So we rather broad and have about almost 10,000 people helping us to develop those new products. Really excited to be able to touch patients around the globe with our organization in pretty much every bigger country that is accessible to us. And with that, hoping to be able to contribute to the cause which we all share around.
It's great to be here. Thank you for having me, Esther, and the entire Milken team, and good to be with all of you. I'm Ashwin Vasan. I'm the Health Commissioner of New York City, a small city to the north, where we face many challenges. Our department has a 200-year-old history of really improving and protecting the health of our residents and facing whatever challenges come our way, and responding with innovation, with aplomb. And our work has influenced not only national but global public health. And I'm very glad to be here with representatives from the private sector, from nonprofits, from other public sector actors, because if one thing is clear and that COVID brought to bear was that when we are aligned, we can do pretty impressive things. When we have common goals in health, we can do impressive things by unlocking our respective strengths. So I'm very excited that this is the focus of this several days here, and that Esther led us off with the discussion on life expectancy, because I believe, certainly, and we are putting this into practice in New York, that is indeed our common challenge, and we can unlock a new generation of collaboration in health if we all agree that this is something we want to work on together.
AmirAli?
AmirAli Talasaz. I'm co-founder, co-CEO of Guardant Health. Guardant Health is a precision diagnostic company with the mission of conquering cancer and bringing more time to cancer patients. We do blood testing across continuum of care. We have blood tests for advanced cancer patients where we tell the physician patients what kind of treatment is going to work for them, what kind of treatment is not going to work on them anymore. About 20% of all advanced cancer patients in the United States are getting managed by using our blood test. And then we have blood tests for cancer survivors, if their disease is coming back or not. and most recently, a blood test for colon cancer screening. And connecting our mission to the topic of this panel, when you think about, for instance, colon cancer screening, where 60 million of people who should be screened are not getting screened, although we have a lot of solutions for them, including colonoscopy and other means. And when you look at underserved patient population, when you look at people of the color, those are the people who are more non-compliant to the cancer screening. Taking 2 days off to get through colonoscopies or having access to some kind of services in order to get preventable colon cancer screening. We bring a new optionality of a simple blood test. We can go where they work, we can go where they live to get this cancer screening done and decrease the mortality of colon cancer. Excited to be part of this panel.
Yeah, I'm excited as well. It's great to join everybody today. Big thanks to the Milken team for having me. A little bit about Geisinger. We are a system in central and northeastern Pennsylvania. I think some folks, we are what you might call a payvider, meaning we are a payer but also a provider. I think we're operating in both worlds, and that allows us to build and focus on clinical programs that sometimes don't happen in our industry because the incentives don't quite line up. And so in our world, for the portion of the population that is both our patient and our member on our health plan side, we have an awful lot of flexibility to focus on programs that simply improve health. We don't have to worry if a food program, for example, is a billable event or not. We could just do it. We still have the other half of what we do where it resembles most others in the healthcare industry, where we're still partnering with other insurance companies, and as an insurance company, also partnering with other delivery systems. I think a big part of our focus, especially over the last handful of years, has been building clinical capabilities, clinical programs, and trying to bring those into settings that meet people and communities closer to where they're at. And oftentimes that's either the home or the work environment, community programs, or even clinics. You know, if you walk the halls of Geisinger, you'll hear us often talk about moving care one click to the left. And I put that in quotes because what it means is folks that we're seeing in the ER and may be hospitalized, is there a way to discharge them from the ER and send them home with proper support so that they don't need a hospitalization? Instead of seeing them in the ER, is there a way to have access be so fast that they could be seen in a clinic? Instead of specialty care, could you take care of something in primary care? Instead of even an actual visit, could it be a virtual visit? Could it be prevention that gets ahead of an issue altogether? That's what we mean when we talk about one click to the left. We know that there's always a place for very sick people inside the hospital, so we're going to continue to develop those programs as well. But to the extent we're able to get ahead and move things further upstream, that's what we're trying to do.
And that, I think, prevention is one of the common themes I think I hear from all of you in how you approach this topic. And I guess I'm curious, Shaywan, I'll come right back to you. What are the roadblocks in reaching that more universally, to getting more people into a sort of preventive care setting where you're not then seeing people really farther downstream?
Yeah, I think there are a couple things. I'd say the big one, I'd start with the payment model. You know, we have a payment model in this country, and you all have heard it. I know I'm preaching to the choir here, but the payment models tend to drive care further downstream, especially if you're in a traditional fee-for-service reimbursement model. And so I think sometimes, and food is just a really good example, there's no CPT code for food programs. So how to invest in that, really, those who bear the risk, those who have sort of a value-based payment environment where they're looking at total health, total cost of care, those are the folks who have a natural incentive to pay attention and invest in food programs. And I think in the absence of those kinds of environments, you have a set of incentives that make it really tough to invest in those upstream activities, whether it's, and food is just one example, but this is true for housing, transportation, or even primary care or services in the home, or even longer physician visits for seniors who may have multiple chronic comorbidities. I mean, these are all examples of things that become possible in a prepayment or population-based payment model that are not possible in a fee-for-service model.
And AmirAli, or sorry, Aswin, did you want to jump in there?
No, I'll
just
put my hand up.
gesturing. Well, talking about Guardant and the services you guys provide, I mean, the whole idea is, well, not the whole idea, but much of the idea is prevention. And so what are the roadblocks that you face in terms of getting better uptake?
So at high level, when we look at, for instance, how much we are spending in our healthcare in this country, about $4.3, $4.5 trillion, out of which about 3.2 trillion of it, that goes to treating the sick or delaying the symptom in a proactive or reactive way. And when we look at how much of that is getting spent on promoting health or preventions or wellness, it's about $1 trillion. And when we look at actually how the healthcare cost is going, there is no future that you can imagine unless you see that the center of gravity goes more toward wellness and preventative investment. And we believe by 2035, 2040, we are going to see a much more balanced kind of investment. But in terms of barriers to get to that point, maybe I just give an example of what we do. There are billions of dollars that have been invested by private sectors and academic centers around having these blood tests for cancer screening. But we have issues on the last mile of bringing these innovations to really patient care. What do I mean by that? So innovations are there. For instance, we expect our test to get FDA approval sometime next year. And in terms of coverage, CMS has national coverage determination, but there is government-funded guideline committees in the United States called United States Preventive Services Task Force, that they go and grade all the preventative measures, not just for oncology, for everything. Very broad scope, but they are heavily underfunded, and their level of funding has been flat during the last 5 years. So typically, let's say for breast cancer, the guideline recommendation updates happen every 8 years. The last time that it happened was 8 years after the previous guideline recommendation. For colon cancer screenings, the guidelines typically get updated every 5 to 6 years. So you could imagine you have all these investment, the tests that work, regulatory and coverage, but because government-funded task force do not have means to look at these innovations, many people would not get access to this test because many of the commercial payers wait for the task force to render the judgment before they give access to the patients. And the solution is really through a significant private-public partnership and raising awareness around these matters, because some of these last-mile issues are generating the main problem in the gaps that we have in healthcare in this country.
Ashwin, you just announced a new initiative, of course, to raise life expectancy. Tell us about how you focused in on the priorities there, and what some of the challenges are going to be to actually reaching some of those goals.
So something's wrong in the richest city in the richest country in the world if the people living in it can't expect to live longer, healthier lives over time, and that we aren't having our children in a world where they can expect to live longer, healthier lives. And when we saw the data from 2020, this is our vital statistics data that hadn't been calculated. We were busy with the pandemic. We saw this at the end of 2022, and it was stark. It was alarming. New York City lost 4.6 years of life expectancy in 2020 alone. And while some of it came back in 2021, we are still 2 years behind where we were in 2019. And the United States is still on the decline and is 3 years behind where it was in 2019. And as a society overall, we've flatlined in the last decade, more or less. So something is wrong with the way that we've structured the incentives, the way that we've structured, frankly, our safety net in our society, if this is the case. And so I'm very pleased to be talking about prevention here, because it will take a fundamental shift towards investing in the things that deliver on health. And so what we said as a city is, can we organize ourselves around a common goal? Can we set out a life expectancy target for our city and organize public, private, nonprofit, philanthropic sectors to drive towards those goals? Can we start to have a conversation within the part of at least the local budgeting process of how we spend against health? And can we do this over time and embed it into our city's planning through law? And so we launched Healthy NYC last week, that's the name of the initiative, to do exactly that, to organize our city. And that's the role of government, right? Set goals, create guardrails, define strategies, but then allow our civic infrastructure in New York City, and frankly this country, to start to deliver. And we think it's ambitious, we know it's ambitious, but we definitely didn't want to be at the wheel and just allowing this to happen. And so that's why we set out the goals that we did. Where did we find the goals? We looked deeply in our vital statistics data at three things. What are the overall leading causes of death? What are the leading drivers of premature death below 65, which in New York City and the country predominantly impacts people of color, black and brown people in particular, and excess death. So where are the last mile problems or the vulnerable communities that are being left behind, but that we learned in particular during COVID must be centered in our population health planning from the beginning. And so across the leading drivers of death, overdoses, suicides, violence, chronic illness, diet-related illness, widening black maternal mortality, COVID remains on that list, and so forth. We are going to be deploying packages of strategies across those three buckets. How do we reduce overall risk? How do we reduce premature death? And how do we target in our programs around excess death? That doesn't mean the city of New York is going to be delivering everything, but it does mean that we can outline a roadmap and a framework for all of the many partners who create our civic infrastructure to help us.
Hubertus, where does the pharmaceutical industry fit into this idea of prevention? I mean, the idea, of course, from the drug industry, I think, is that by using medicines, you can prevent worse outcomes. And so that's a value-saving proposition to the whole healthcare system. Of course, pricing is always in the limelight. The Inflation Reduction Act has drawn many challenges from the drug industry, including from Boehringer Ingelheim, to the drug pricing provisions there. So how do you make that value proposition, especially as you look across the United States, where we spend more on medicines than any other country, with access? How are you thinking about that?
Maybe let's start from where the colleagues on the panel have pointed out, and let's look at prevention one more time. I think there's one element that we see, understanding the pattern of pathologies of diseases, that might make quite a significant difference in it. It's about education. Educating the population about how diseases develop, how they can be prevented. Take metabolic diseases. Food plays a role, exercise plays a role. Then you start getting into the continuum of early diagnosis, we heard that, and bringing that then together at the end to provide pharmaceutical intervention to those that have progressed to a stadium that then need it, will allow these systems to be more efficient. But the more we can prevent of patients actually progressing to the stadium of needing a pharmaceutical intervention, I think the more robust we can build the systems, and my colleagues have all alluded to how important it is to make sure that prevention keeps patients actually healthy rather than in a state of disease. And that's, speaking for my company, that's what we've been trying to learn from many social entrepreneurs that we have been engaging over the course of the last 10, 12 years. They start to develop models that will help us as a company to actually bring that element of education, of prevention, to a broader population of patients, whether it's communities that are underserved, but also, every one of us. We can all learn how to prevent a disease if we learn what we need to do so. So that's a large role. Now, access, is something that we as an industry obviously also play an important role. Now, my plea there would be if we do all the elements, and like you pointed out, Ashwin, you said we need to bring these goals together. If we put efficiency in our systems, and if we make sure that the patients that really benefit from the drugs and that we can then generate an outcome for have access to those drugs, I think the overall gap is going to get small.
Mm-hmm. Angela, one of the things you've talked about is building resilient communities. And one of the themes we've heard about already here on the panel is the idea that COVID really focused in on one singular goal and that it really changed some of the ways people work. Tell us about how COVID provided potentially a different model or a way of focusing more on the real local community level in your work.
I'm going to slightly answer your question differently in that as I'm listening to my fellow panelists, I keep thinking about the fact that my vision for United Way is to really be that platform and ecosystem that people are willing to use and to leverage. And the reason I say that is that we have proximate relationship with individuals that live in communities. And as I said, we cover more than 95% of communities in the US. We're the only organization that does that. So when you think about what impacts a community, what impacts an individual or families, and when you think about you want to educate those families or you want to move the needle with respect to a particular issue, then we are there and are able to take those innovations, to be able to educate folks, to be able to move the needle in a way that no one else can, but it can only be done, as has already been said, through partnerships. So for us, we work with community health workers. As I've already mentioned, we have a 211 hotline. The other thing I can share is our partnership with AARP, where just this year alone, we've been able to connect 20,000 caregivers, unpaid caregivers, to at least 3 to 5 resources to support them in their work. We're the ones that when people call, we can get them for transportation to get to a primary care visit. Or when they say they need food, we register people to get access to Medicaid, or we register them to get SNAP benefits. So when I think about this gap that we're talking about, when I think about the ingenuity that's on this panel in terms of what the companies are innovating and how we can, again, sitting in this country with all of the assets in place, we should be able to mobilize in a very intentional way to make things happen. So with respect to your question around COVID, yes, we were able to, with the calls, working with local governments, to even disperse ARPA funding for families, making sure families had meals, transportation, or telehealth, helping to enable them, telling them where they could go for their vaccines, helping them get their vaccines, working to make sure that as we educate people and talking with them, we're doing so in a way, in a language that they understand, being spoken with by people that look like them, that understand cultural nuances, and on and on and on. So I'm still encouraged and hopeful for the US. I know that there is a way that we should be able to solve for all of these problems. They're not insurmountable. I just got off the plane from Ghana yesterday, and I take a look at what I see there and in the other African countries in which we operate, and then I come here to a panel today to discuss this. We have so much richness in this country. We should be able to do it. I think the problem is, 1, the will, to 2, work together.
How widespread right now is the 211 service that you mentioned? How widespread is that right now, and what are the sort of barriers to getting it really so that everybody knows about it, everybody can benefit from it?
So what's really interesting is that 211 has been around now for several decades. United Way operates about a little over 60% of them across the country. We contract with states, or we'll contract with cities, or sometimes we operate them on our own. But believe it or not, what's unfortunate, as I said, we take 20 million calls a year. We don't receive any federal funds. We literally, as a nonprofit, are raising the money to do the work. And what I think people miss out on is, I can tell you on a daily basis what are the uptick in calls in a community or a zip code and trends that are happening. I call it the canary in the mine shaft. For example, we were getting calls and knew before the federal government that baby formula was off the shelves in grocery stores. And so when you think about the power, and then when you talk about, even Ashwin was talking about data, so we actually have a national data platform, and again, we have all this data that we sit on, but again, we're a nonprofit trying to figure it out without much support.
Send it to me. It sounds like great story idea generation. I would appreciate to know about it. Ashwin, does New York City use 211?
We do, and the United Way is a fantastic partner to us. And I think Angela's spirit is exactly right. We have to, if we have common goals, if we say we want to increase life expectancy, as we've done in New York City, if we say as a part of that strategy, we have to deal with who's dying too soon and from preventable causes, then we have to go into communities and we have to build the kinds of programming that will catch disease early, that will get people into care early, that will help folks navigate a really complex social and healthcare system. And that starts with our community organizations. We learned during COVID, the height of COVID, that government has an obligation to get its resources into the hands of the organizations that are closest to communities that need it the most, and that have the credibility to actually get people into life-saving services. So we built a program called Public Health Corps, New York City Public Health Corps. Over 100 community-based organizations, not the ones that ordinarily get government contracts that have the administrative capacity, but small, sometimes 5, 10-person organizations. We got incredible amounts of federal emergency dollars into their hands to do community health work, to do enrollment into care, to do vaccination, to do distribution of PPE. And so if we can do that in an emergency, if we can do that when we're awash with extra dollars from the federal government, how do we organize our systems to do that during peacetime? Number one, we need a goal, and I think life expectancy is that goal and the inequities underneath it. Redressing that has to be a focusing effort. And then number two, it's about dialogue and alignment. How do we come around together and say, who's in the best position to deliver? And what we'll find is that it's often not government. It may not even be some of the private sector representatives here. It will be communities that can actually deliver on what we all need.
Well, that idea of alignment, I mean, Jaywan, you were talking about the idea of food sort of as preventive care. It can work perhaps in a system like yours where the payment incentives are there to maybe capture that value down the line. But we have such a fragmented system in the United States. And I wonder, you know, and maybe I'll direct this to the industry folks on the panel, AmirAli and Hubertus. Is our system set up to be able to enable the most people to benefit from the incredible technology Esther was talking about in our introduction? Or do you have the pressures? I mean, I was at CNBC for 9 years covering the pharmaceutical industry. I saw where the pressures were to make your prices as high as possible, to be able to make as much money as you possibly can from your products, particularly in the United States. How does that, you know, result in who gets your medicines or your benefits from your tests? And whoever wants to take that one.
Okay, I guess I'm the first one in line here. I think we all share one goal, and that is getting medicine to those that need it. If we develop medicines and they don't reach the patients that can benefit from them, we don't deliver on our purpose. Having said so, the complexity of the system is high. And the complexity is driven by many players in it. And what might seem to be a higher price at the pharmacy level does not necessarily mean an income, equal income on the basis of the industry. So changing the price level at the level of the patient needs to involve, like it's been mentioned many times before, many more players than just that of the industry. Having said so, I would like to go back to a point I've tried to make earlier. We need to improve the efficiency of the system, which will then at the end render higher and better outcomes. Outcomes should be what is being measured, not cost. Because if we can compare the outcome and the efficiency of a treatment, we can measure it against the benefit that it brings to bring a depressed patient back into a working environment, to allow a heart failure patient actually to walk the stairs in the house again, participate in a community life, contribute to it. I think currently we are lacking the ability to really look at the value and are being driven mainly by the cost. And that, I think, veils a little bit the discussion about the ability and the necessity to drive the efficiencies of the system. We as an industry, we understand disease patterns, we understand how to measure outcome, and we're willing to contribute to it. But as said in many of the other points, we cannot carry it alone. We need to do this together with the goal to close the gap, improve health of patients. And I like the idea of let's measure lifetime as the ideal that we all want to deliver on. And I'm sure we can all and will all be able to improve that.
I would like to also make a comment about this matter, about the pricing. Like, as one of our panelists mentioned, one of the parameters that goes into pricing determination by the companies is all the level of investment that goes in that specific asset to make it accessible for the patients, obviously. So if we go back to the example that I mentioned, that an innovation which is approved takes like 5 to 7 years to become accessible for patients, companies would consider all the cost of 5-7 years of sitting on a specific asset into, at the end, what the pricing should be, at least to recover those kind of investments. So if we work together, we bring efficiencies in a right way into our system, the economic dynamics of product access would be very different. And we can have more affordable care and healthier population. I think another parameter that we should discuss about maybe these closing gaps and equitable care is the trust in the system. When we are talking about, even during the R&Ds, during the clinical trials, in order to bring our test, our intervention, our drugs to the communities, to the underserved patient population, they need to feel they were part of the trial. They were part of the innovation. They were part of the trial. So doing an equitable way of R&D, equitable way of clinical studies and enrollment is very important. And it can be done. We can do it together as long as we commit to it. And it's work. It's hard. We've done it in our 20,000 patient study. We are proud with the percentage of people that we enrolled in the non-white kind of section, but it was not easy. But we know it's doable, and as long as we commit to it, that level of trust can get also improved.
As I was thinking about the sort of the paradox we're talking about here, one of the examples I think that came to mind of something that really sort of portrays what we're talking about is perhaps the sickle cell CRISPR gene therapy that we may see come to market as early as December if the FDA gives it the green light. Jaywan, I wonder, how do you look at something like that? And the idea, as AmirAli was just talking about, sometimes new technology takes 5 to 7 years to actually reach many people. This will be an extreme example of that, perhaps, because these therapies often cost like $3 million a year just for the therapy itself. and affects primarily African American population. How do you look at Geisinger about perhaps covering and providing something like that?
Yeah, we were actually just talking backstage about some things that we've done historically together with folks like Guardant. I think the world's a little more open for us, it gets to your question, because we have this payer lens as well. So we're able to actually view a given patient or a given clinical condition more longitudinally. I think that helps an awful lot versus being confined into sort of an episodic evaluation where it becomes really difficult to figure out, is it sustainable to support some of these technologies or medical advancements? If it's the right care and there's no other treatment, of course, that's the right answer. But you also, I think we as a society need to think about how do you make that sustainable? And what we've tried to do at Geisinger is evaluate things through that more longitudinal lens, sort of a population-based, community-based, multi-year time horizon. And when we're able to do that, I think with regard to a specific patient who may need the drug, I think it gives us a lot of flexibility. We don't have to argue with the payer, for example, because half the time that payer is us. And so in that world, we're able to invest in those capabilities. I think the other thing to note here is that how we figure out what are the right clinical situations to use a drug or an intervention. I think there's an awful lot of variability across the industry in how certain of these technologies are used. And what we've tried to do, we're big believers in trying to create care pathways, reduce unwarranted variation. And by doing so, we're able to make sure that any given technology, any given medication is really focused on those who can benefit most. So I think this question of appropriateness of use is also a deep consideration for us.
I'm going to ask you a hard question, which is you're in one system that has this sort of unique model. Does what you're doing there work in places that don't have that model where you're the payvider?
I think it does. I don't know that the payer and the provider need to be one and the same necessarily. As I mentioned, the other half of what we do, we still partner with other payers. And as a payer, we still partner with other provider entities and independent physician groups. But you could still introduce concepts like what we're talking about, whether it's introducing care pathways. What might be the most appropriate for that CRISPR therapy? What populations, what situations would that be appropriate in? I think those kinds of things you can introduce even in terms of arm's length dealings between payer and provider, where you're either in a value-based payment world or a collaborative one where you're passing data back and forth. You have the information to better manage the patient / member, whatever the case may be. I think those things are doable even if you're not completely integrated in that payvider world.
You mentioned, AmirAli, you mentioned trust. As we think about life expectancy, I interviewed Rob Califf, the FDA commissioner, several months ago, and he was mentioning he thinks one of the main reasons life expectancy is declining is misinformation, as maybe an upstream part of it. You don't look like you necessarily agree, so I'd be interested in hear your reaction to that. Maybe I'll ask you that, and then I'll frame my question. What do you think about that?
No, I'm thinking about the link. Misinformation is certainly a massive issue in terms of our engagement in our own health, so at the individual level. And make no mistake, health is a choice, but I think in this country we've organized it mostly as an individual choice. And what we're saying in New York City is it's actually an institutional choice. It's a cross-sector choice. And we have to make choices, you have to organize yourselves. But it's hard to organize the actions of communities when we're basically fighting an information ecosystem where the foundational elements of health are being debated. I think one of the biggest challenges with the pandemic, and I don't want to rehash this, but is that from the get-go, the fundamentals were being argued. So it put people in positions like mine at a huge competitive disadvantage in terms of getting a positive message out there around how to take care of yourselves when SARS-CoV-2 arrived. And so we built at the New York City Department of Health an entire misinformation unit, whose sole focus was to look at which communities were being disproportionately targeted with hyper-local, factually incorrect messaging around the vaccine or how COVID spreads or so on and so forth. And what we found is that we were able to target our resources, outreach, communication, even ad buys, even media buys, to those communities by doing things in other languages and disproportionately investing in this. But government is very much, starting at a different point than the tech industry and bad actors in this space. So do I trace it to life expectancy? Certainly, when it comes to the pandemic. We lost a lot of lives due to misinformation. The question is that going to have bleed over into other parts of our life? And we're watching overdoses in particular very closely to see whether there is a misinformation ecosystem growing around that. We're watching mental health and suicides very closely to see what's growing around that. And so unclear, but it's great that he's lifting that up because it's a challenge for all of us. We are definitely, the health ecosystem that we all are a part of is very much fighting with one arm tied behind our back against the tech, basically unregulated tech apparatus.
Angela?
So when I'm hearing the conversation and I'm thinking very simplistically, and what comes to mind for me are maybe two and a half things. First being education and educating the individual in order to allow them to make the healthy choice, but then access. And so when you think about that word access, I think underneath it there are several things that come to mind. And when I think about our system, access means, do I have either insurance or do I have the economic wherewithal to even be able to pay for healthy services or basic items like food or shelter, some of the social determinant parts of access to healthcare. I also, when I think about access, I think about institutions and systems that have been in place for decades. And we are at post-COVID, in a completely new era. And yet we're still operating the same systems. And why can't we reinvent or retool what exists now to meet people where they are? So where can they have access? Where can we bring the support to them? Where are they where they don't have the access? What we saw during COVID was, let's talk about pre-COVID. Doctors said, in order to treat you, I have to physically see you in my office. COVID happened. Oh, I can see you on your phone. That's not a problem. So where are we now post-COVID? Are we in a hybrid situation, or are we still like, yeah, let's go back to the old way of doing things? So what we have to really do is, again, to go back to my whole, do we have a will point to make a difference, but access means what? How are we defining access? And access for whom? And how is it paid for?
Well, and you mentioned, why can't we? So I guess my question to you is, why can't we? And you mentioned the will is part of the problem. Where is the will lacking?
Money. Okay, I mean...
But can I?
Yeah, go ahead.
Can I actually say something? I was so glad to hear Esther and others mention the unsustainable trajectory we are on in terms of health spending. We are, and now there's a movement to say, how do we liberate these dollars from this system that's incentivized not to deliver on health, and how do we start to divert it towards the things that we know will deliver value? Food as medicine, housing, transportation, so forth. But what did we do during COVID? We brought extra systemic funds to bear in an emergency and built a whole lot of stuff outside of the apparatus of revenue-generating healthcare. So can we start to get real about creating a new financial system for social needs, for health, that doesn't rely on an extraordinarily complex and baked-in set of incentives to deliver on the things that Angela works on every day, that I work on every day, that all of us work on, but at the same time, it's really orthogonal, the way we pay for healthcare and delivering on health. And I think we need to have an honest conversation with ourselves after the pandemic about whether we're barking up the wrong tree and whether we can liberate new dollars for health that actually go into the things that deliver the best ROI on health, as measured by life expectancy or as measured by however you want to measure it, but something that is beyond control and absence of disease.
And by barking up the wrong tree, do you mean going back to systems we had pre-COVID, or what does barking up the wrong tree mean?
I mean, we have a dominantly fee-for-service healthcare system in this country that will always have a volume incentive. We can create new financial instruments, new payment models to try to shift that slowly. It's been years. We've had value-based payment for a while. I don't see the value coming out of that movement. I don't see the entire system shifting in the direction towards health, right? There's islands of excellence in a sea of need. So I'm saying, and especially the COVID experience taught us, we can build pop-up clinics, we can build community health worker programs, we can deliver on digital health solutions when we liberate those dollars from this really tightly wound system with a set of financial incentives that are really hard to unwind.
Yeah, so I love the term liberate the dollars. I think that's exactly right. Getting back to the question about telemedicine, because I think it's a really good example. What changed after the pandemic, or as we entered a different phase of the pandemic, that was no longer a billable event. So it gets to Ashwin's comments about fee-for-service medicine and sort of being in a population-based payment versus a fee-for-service payment. A virtual visit only under certain circumstances prior to COVID was ever recognized as something you could bill CMS, i.e. Medicare, and other payers would typically follow the Medicare payment system. During COVID, all those things were lifted. You liberated those dollars, to use Ashwin's term. There's a lot of flexibility, but those flexibilities then shifted back and reverted. So to your question about what happened, why are those virtual visits a little more challenged now? Now you're back in a framework where it's got to fit certain scenarios, and otherwise those aren't paid for.
Can any of this be changed without some huge government intervention? Can the system evolve without trying to reach some agreement in Congress, which seems, not easily doable? That's up for anybody.
Maybe I can start so that, we can debate some of the big changes in terms of healthcare system in this country, universal healthcare versus what it is, and some of the big moments. But what I can tell you is even within these health systems, there are ways to bring some meaningful change as long as public-private partnership happens effectively, as long as the right set of awareness is built. I give you an example, in terms of some of the funding and money issues. There are some quality scores that we have in our health system for providers and health system that based on those quality scores, if they're showing some kind of improvement, there could be some Medicare Advantage benefit in terms of the claims and the fees associated with their Medicare Advantage. Just with putting the right quality scores for health systems, and they follow it very closely and very tightly, we can generate some kind of behavior changes. And in fact, by putting some quality scores which are not up to date, in fact, we can disincentivize these health systems to go after some innovative approaches that can put that quality score at risk. The point is, I think even within this current healthcare system, there are ways to make some improvement instead of just waiting for some kind of big disruptive changes.
Oh, go ahead.
We often talk about health as in a series of moonshots, like aspirational targets. But we fail to see something that's out there that we use across a host of other sectors, which is industrial policy. We have industrial policy for healthcare. We have industrial policy for microchips. We've used it for big infrastructure throughout history. And what does it mean? It means government setting goals, superordinate, bigger than any of us can achieve on our own, setting some financial incentives, even liberating some capital or creating some capital. But who does a lot of the work? It's the private sector, it's philanthropy, it's nonprofits, it's the civic infrastructure filling in that space towards a common vision. We don't have an industrial policy for health because we haven't agreed about what we want. What are we solving for? What is the common health project of this country? We're trying to lay it out in New York City, but we need the rest of the country to also follow. And I think that's the kind of government action we need. As the only government representative, I feel like I have to speak up for government. It's not that we need to do everything. In fact, sometimes we shouldn't we should do a lot less. But what we do need to do is set out a vision that we can all get behind, that says this is best for society. And we do this all the time. We select winners and losers, and we select common projects when we see that there's a threat. The CHIPS Act was the latest example of when we see a national security threat, we step in, we intervene with clear action. Well, this is a threat. I think those data show you that's a threat to our project. That's a threat to our democracy. That's a threat to our society and its future if we don't step in. So it's going to be on the government to set a target, set some goals, and unlock an industrial policy for health that we can all get behind. And that only then will we start to shift some of these incentives towards health and not just care.
You know, when you just said what you said and then said that's a threat, it reminded me of the conversation around climate. And we see how things are just taking place and the impact of climate change. And yet, what is it? We almost need a psychologist on this panel, because what is it about human behavior that you can face an imminent threat to your well-being and still stay stuck? Is there a psychologist in the house?
That's a great question.
I think maybe to add a couple of thoughts, innovation is going to be one of the keys to answer many of the challenges ahead of us. And that's based on your proposal to have an industrial policy behind it. It's something we need to keep in mind. Now, how can we keep patients out of hospital? How can we improve their life quality, not only in the sense of feeling better, but actually making them more productive, and thus directly also reducing the cost for hospitalization. ER rooms were a big issue in the earlier discussion. If people don't need to go there because of the right intervention with the right outcome, it's going to help the system. So let's not lose sight of what innovation can actually add to the system. The other thing is we need to understand our data. We need to share it. We need to be able to use that transparency in an unbiased way. I think that's another learning curve ahead for us. We still have it in pockets. We should respect the ownership of data, which is usually with the patients. That's who it belongs to. But making it transparent to everyone, getting an unbiased view, using technology to mine these huge lakes, oceans of data, is going to be one of the key drivers to efficiency, i.e. liberating dollars within the system. I'm absolutely sure about that.
We're getting down to our last few minutes, so I'd like to sort of ask each panelist, and I'll start with you, Jaywon. This is the first panel of a 3-day conference filled with really fascinating conversations. What do you want to leave people with to spur more conversations about this topic in particular?
I think maybe a couple things. One, I think we're getting a flavor of just how complex we've made our healthcare system. And I think inherent in that is maybe we've made it challenging as a result. There is still good, though. I was going to mention this earlier. You know, if you look at just even some of the work that's gone on over the last couple decades around readmissions, by having that be a focus, by having government kind of anchor that as a quality measure, I think our readmission rates across the industry are significantly lower. So that's there are bright spots in the middle of this mess that we've created. But I think over the next couple days, I'm looking forward to just the digging into each of these issues. And I think in our world, if you haven't noticed already, I think payment incentives, I really do believe it's one of the biggest challenges to creating and getting on a better path. I also think it's a big challenge around equity in health as well, because the payment incentives around fee-for-service disproportionately favor commercially insured populations, which tend to be better off financially, and as a result, you widen the inequities in healthcare. So I think the payment component is something that I think is near and dear to us, but also something that we would argue should be near and dear to any big conversation around the challenges of healthcare.
AmirAli?
So maybe I would start with sharing a lot of optimism about the future of healthcare. The engine of innovation is really working well. There are room for improvement, but innovations are very strong on diagnostic side, therapeutic side, across the board, intervention side. Let's figure out how could we work together to solve some of the access issues and some of those last miles that we talked about. That last mile is generating a lot of these gaps in equity. And the only way to really make it good progress is through partnership. It's a very noisy world. Nobody can do it alone. We need public-private partnership, amplifying information, even if we cannot suppress misinformation, and making sure that together we can solve this issue. That's the only way to get it done.
I have a lot of hope that we're at a moment to take on some of these structural challenges in the way we've organized health and healthcare in this country. So even though those data you saw are concerning, the data we saw in New York City alarming, I see a moment of great opportunity and hope. And when we launched Healthy NYC last week, it's a hopeful vision. It's a hopeful vision that we can align around a common project, that we can break down some of these silos and barriers we live in and get behind a project that is, as Amir said, bigger than the ability of any one of us to achieve on our own. And that means an unprecedented level of cooperation, collaboration, alignment, dialogue in places just like this, right? Bringing together all aspects of our really complicated but really innovative healthcare apparatus in this country is essential. And so I hope you will leave here after 3 days with more hope than not. And the sense of a moment in time. Because in a year from now, if we're here and we're lamenting the same data, but we haven't taken any of the steps to reorganize ourselves, then we will have potentially missed a moment. I think we have a chance, particularly in the next 12, 24 months. Who knows what will happen in Washington thereafter. I think we have to seize this moment now and define a new common project for this country, because we deserve to live in a society that is healthier and with the expectation that we'll live longer and better lives.
Well, that's tough to follow now, I must say. So I would fully sign to that shared goal. I would also like to share with this room and everyone beyond it is that there's great breakthrough ahead of us on the therapeutic side. I think we've just seen the edges. And that innovation will rise the tide for everyone because it will improve the system. Last one point. I can best speak for the country I know best. But the discussion we currently have and what we understand, bureaucracy does not improve the system. More regulation does not help the system. To liberate the dollars to improve access, to improve delivery, improve outcome, I think we need to create more space for everyone to be innovative. And, as mentioned many times before, we need to learn to speak with each other, not so much about each other. I think that's another big key there. Thank you.
So, my charge to each and every one of you is this. Given your sphere of influence and your seat at the table, I want you to commit to thinking about the one thing you will do in partnership with someone else to move the needle in American healthcare. All right?
I'm ready.
You give us such a good point to end on, but I'm a TV reporter, and we use every last second we absolutely get. So I see we have 4 minutes and 7 seconds left, so I want to ask one more question. You guys were very pithy in those last responses, and I didn't expect that. I want to talk a little bit about innovation. I mean, we've talked a lot about the problems with getting to that innovation, and I think each of you has different forms of innovation in the spaces where you are. And so, Hubertus, maybe coming back to you, what is the area that you see the most promise in for advancing technology right now? One space that comes to my mind, and I'd be curious your thoughts on it, is the GLP-1 obesity drug space. Is that something that Boehringer is heavily invested in? How will that change things?
Metabolic diseases comprises of many comorbidities. So we will be addressing with those mechanisms a whole universe that is, as we understand better and better day by day, linked much closer together. If you were to ask me what I'm personally most excited about, I think mental disease is going to be a field where in the next 5 years we will see significant breakthroughs that will change the trajectory of patients. I haven't seen any innovation for the last 40 years. I'm very convinced about it.
I have so many follow-ups about that, but I'm not going to go there. AmirAli, how about you?
I think when we think about early detection of diseases in general, it's going to really help to move and shift the center of gravity in our health system from treating sickness to promoting health and wellness. It's beyond oncology when we are thinking about early detection of neurodegenerative diseases, Alzheimer, Parkinson. There are not a lot of intervention because we cannot detect those diseases at the right time. And just that early detection of disease would foster a lot of innovation on the therapeutic side. The reason there are a lot of advanced cancer drugs, let's say for lung cancer, is because majority of people get diagnosed with late-stage lung cancer. Now imagine a world that vast majority of people get diagnosed with precancerous or early-stage disease. Just through the data, biological insight, and incentive that diagnosis at early stage would generate, we are going to see more intervention, more therapeutic, more medical devices to manage diseases at early stage to restore that health. So I'm very excited about what we could see within the next 10 to 20 years.
Jaewon, how about you?
Yeah, I think we'll have to, whether we like it or not, find better ways around chronic disease. So I think metabolic is one. There are many, many others. I think the challenge will be because our system is set up, and the payment system specifically is set up to address episodic interactions, and chronic disease by definition is longitudinal. And so there you have a disconnect. I think the other is, to the extent we have existing interventions around chronic disease, they tend to be very labor intensive, and there simply won't be the human bodies around to sustain those models going into the future. So I think a lot of trains entering the station, if you will, that point to we're going to need a different solution around chronic disease.
Ashwan?
Two things. Care delivery. And again, going back to the COVID experience, we brought care to people's homes, to people's street corners, to pharmacies, to to police stations and fire stations. I mean, we used the entire civic infrastructure to deliver care in an emergency. We have to learn from that, as well as telehealth. We have to expand our notion of what it means to deliver care. I think in an environment where wearables and where people's self-generated engagement with their health can match our ability to bring care to where they are, that's one area I'm very excited about, and I hope we learn. Number two is data. Hubert said this. We have to get better, and I think AI offers an important opportunity to really get past our administrative silos with data so we can get into a population health mindset using real actionable data.
Angela, final word?
Final word is I'm just excited to be alive with this group of smart people because I'm excited about the change that's getting ready to happen.
Here, here.
Thank you, everybody. Thank you, guys.